I will say talking about end-of-life issues is not easy, but it beats talking about obesity during mealtime. It's a nice break. So I'll tell you just by way of background, I used to work right over here at Research Triangle Institute, and in fact for 7 years I taught health economics at Duke. And then when Duke started the university in Singapore, we thought it would be kind of a neat experience to live in Asia for a while. And that was in 2009, and what I thought was going to be a 2-year gig has turned into a 6-year gig, and we're probably going to be there for many more years. So it's a neat experience. I'd be happy to talk about that afterwards if anybody is interested. About my 3rd year over there, I was still doing a lot of obesity-related work, but there was the Center for Palliative Care, the Leanne Center, and they funded me on a project. I was very interested in understanding why in Singapore some people choose very expensive, very aggressive, life-extending treatments, and other people choose to die very inexpensively with very little treatment. And it was unclear what were the factors that predicted those differences. And so I was quite interested in that, and we wrote a small grant to look at that, and then that grant led to another grant, which led to another grant. And then the center was actually looking for a new director, and I sort of got tapped to take over that role. And so now we have a very extensive and wide-ranging research agenda and education agenda around palliative care, both in Singapore and in Asia. And in fact, as you guys may know, end of life is where much of healthcare resources are spent, and frankly, they're not particularly well spent, and people often die in pain, not at their place of their choice, and not getting the treatment that they like. So it's a really important area for research, and in fact, people always think about it, economists are trying to figure out how we can save money, but in fact what we're really interested in is understanding choices and preferences, and how can we deliver a healthcare experience or an end-of-life experience that helps people sort of move to the next path at in a way that meets their preferences. And so that's really what I'm going to talk about today. I'll give you just a list of many of our collaborators. And as you'll see, understanding preferences is actually quite tricky. So I'll talk a little bit about the background for this research in Singapore specifically. And Singapore is quite unique in how health services are delivered. So I'll spend a little bit of time talking about that and motivating this particular study. And then I want to talk to you guys a little bit about the methods that we use to do this work. And the methods are actually really cool and have been applied to some innovative areas, and I'll talk about that. And then I'll talk about results from 3 different samples: an older adult population, a patient population, and a caregiver, a family caregiver population, and why each of those samples is potentially relevant and interesting from a policy perspective. And then I'll talk about the implications of the results, and then a little bit on physician choice, because the reality is physician preferences probably have the single largest impact on treatment, than even larger than patients and caregivers. And whether that's good or bad is, I think, debatable, but we can talk about that as well. And I'll try to cruise through this in 45 or 50 minutes or so hopefully we can have some discussion towards the end. So let me just spend a couple minutes on background of Singapore. I'm not sure if you guys have had much experience or introduction. So Singapore is a pretty small country, and in fact there's about 5 million people in the whole country. It's on the southern tip of Malaysia. It's not in China, by the way, although people seem to think it is. I often get introduced from Singapore, China. Now, Singapore has a rapidly aging population. So in fact, if you look up here, in 1970 the median age was less than 20, and in fact now it's over 38, and in fact that's expected to increase dramatically. Now, Singapore, back in 1970, you had 13.5 working people for every person who was over 65. That number now is actually about 4.9, and by 2030 they estimate will be down to 2.1, although this likely will never happen because Singapore is basically shipping in a bunch of foreigners and trying to give them citizenship to keep the population growing, because if the population doesn't grow, they're going to have real problems, right? So these have implications for end-of-life care. And I'll talk about that in a second, but let me just tell you one more fact. So currently in Singapore, they have the highest female labor participation in the developed world. Roughly 75% of working age women are in the labor market. And in fact, they have the lowest fertility rate, and by the way, the lowest breastfeeding rate, not unrelated to this, also in the developed world. So fertility rate is actually around 1.2 right now, well below replacement rate. The government runs a dating service. They run a baby bonus program, so if you are willing to get pregnant, you can get a bonus. Unless you're Filipino, in which case you are automatically shipped out of the country. So that's a law as well. So yeah, if you're a Filipino helper, Indonesian helper, and you get pregnant, whoever you're working for gets fined and you have to leave the country. So there's some interesting things about it. So, but in fact, and I've never been on the dating service, so I can't say much about it, but they're trying to promote baby making any way they can. Now, let me tell you why these things are relevant for Singapore, or for aging. So, people talk a lot about sort of traditional values or Chinese or Asian values. Well, the context of Asian values basically was, when somebody gets old, their family takes care of it. And usually it was a woman who would take care of their daughter, right? Well, what happens when you have few daughters, and the few daughters that you have are working full-time in the labor market? Well, those Asian values start to go away pretty quickly. And in fact, economists tend not to use sort of Asian values or those types of things to explain behavior. We're more likely to explain things based on prices and opportunity costs. And in fact, even not just in Singapore, but even in countries like Japan where you see aging, you start to see things that look very Western in terms of the way older adults are cared for. You start to see people hiring, actually a lot of what they do is they hire maids or day workers to come in and take care of older adults. They put them in old age homes the way we do. And in fact, Japan actually now will sometimes ship them to Philippines. Right? So they have Japanese old age homes in the Philippines where it's much cheaper to care for these people. So this traditional Asian value is fading away very quickly because the economics have changed. Now, let me tell you a little bit about the healthcare system because this is also quite relevant. So Singapore's healthcare system is called the 3M system. And I'll talk about the 3Ms in a second, but basically it's very focused on individual responsibility. So individual, then family, then government. And so basically they don't have, or at least historically, they didn't have the types of entitlement programs that we have here, like Medicare and Medicaid. So people were on their own or used their family to pay for most services. Right? So people are highly used to using their own money and making decisions about health treatment. And in fact, Singapore is very effective in using price and cost to regulate choice. Right? So they're very used to basically having taxes and subsidies to try to encourage or discourage certain behaviors. So price is really influential in dictating behaviors in Singapore. So let me talk to you a little bit about the 3Ms. So the first M is essentially, it's called MediSave, and it's a high deductible, or I'm sorry, it's a health savings account. So everybody who is employed gets one of these health savings accounts. Your employer kicks in some money, you kick in some money, the government will kick in some money, and you use that money really as first dollar coverage for health services. Now, of course, the wealthier you are, the larger percentage gets kicked in, so you have more money. So poor people or married women who aren't in the labor market or people who are self-employed, they tend not to have these things, and so they have very little money or no money in these health savings accounts. So that can be a real problem. Now, one of the interesting things about these health savings accounts is that they have family-based risk pooling. So if I run out of money in my account, if I'm an older adult, I can tap on my kids or my siblings or my parents potentially to pay for these services. And this creates some interesting dynamics. In fact, I've had my students tell me that they try to get their parents to quit smoking because they don't want to have to use their MediSave savings to pay for their unhealthy habits. And in fact, what we see now in Singapore, one of the major problems is that these older adults are living quite long. They're spending all their money in their health savings accounts, and then they start tapping into their kids, and then the kids don't have any money in their accounts. So you have this downward spiral in health savings accounts. And one of the reasons that you have that is because the second M, called MediShield, is like a high deductible catastrophic health plan only for inpatient services, but the problem is it capped out. It had age, annual, and lifetime caps, and once you're capped out, you're done, and then you either have to use cash or your MediSave account. Now, unlike Medicare in the US, which kicks in at age 65, historically you aged out of MediShield at age 75. you were done with government-sponsored health insurance. So think about the incentives that creates and how different a society is where it says you're too old for these types of services. Now, they did that historically because old people are where all the money is and they wanted to keep premiums really low, right? But now that the population is aging, they've had lots of pressure to increase the age cap. So they increased it to 75 not too long ago, then it went up to 80, then it went up to 85, and just in the last 6 months, they've created MediShield Life, which means you have lifetime MediShield. But now what they're finding is they got to pay for it, and so the premiums are going way up. And so where you used to have very high enrollment, now some of the younger people are saying we're not interested. And so I'll tell you, in what they've done now is something very similar to the US. They put in a mandate and said everybody has to get MediShield. So it's starting to look a lot more like the US system. The third M is called MediFund, which is sort of like a Medicaid account or Medicaid in the US, but it's not an entitlement program, and you don't know whether you're eligible until after you get the services. So, and in fact, in the whole country, MediFund is about $50 million. So in that sense, not like Medicaid at all. It's very cheap. And so I'll show you a slide in a second. Most of the money that people spend for health services in Singapore is funded out of pocket or somebody's MediSave account, because MediShield is used only for inpatient services, and MediFund, you got to be really poor to get it. And first they'll go after your family member's MediSave account, and in fact they can force family members to pay if they want to. And you have a lot of husbands who decide they don't want to pay for their wives' health care, and so the government will come in and force them to do it. That's an interesting dynamic. So if you look at the numbers, 75% of the numbers come out of either MediSave or out of pocket. So the health insurance scheme in Singapore is only 25%, right? Very small, but it's changing a little bit. MediShield is about 11%. So it's clearly not a universal or publicly funded plan like Europe, for example, very different from the US, which has a very strong Medicare program and a very strong safety net for low-income individuals. Quite the opposite here. So you can ask the question, well, how has the system performed? And in fact, the reality is it's hard to argue that the system hasn't done well, at least on average, where you have, if you look at metrics like life expectancy, infant mortality, Singapore is probably among the top 5 in the world in terms of any measure of health status. So the system has worked, but the problem is with rising an aging of the population and rising rates of chronic disease, and everybody running out of money in their MediSave account, you have, it's just unsustainable. So the government has recognized this and basically have acknowledged that they're going to have to make some changes, right? And the other challenge is, although it's done well on average, just like in the US, there's lots of inequality, so poor people really have not done nearly as well as wealthy people. And lots of anxiety about the future with everybody running out of these health savings accounts. Now, I will tell you politically, and when I teach my health policy class, one of the things I argue is that the health systems of a country often mirror the political systems in the countries they emanate from. And Singapore is really a one-party system. It's really pro-business, and it's set up like essentially like a for-profit country, for example. It's very efficient. And the health system is similar, individual responsibility, using prices quite a bit. But as countries grow wealthier, there's oftentimes a push for greater equity. And so Singapore is a wealthy country. They're seeing that push for greater equity. And although it's a one-party system, the party is always worried about its ability to keep control of the population. And so they're worried, and so they're making significant changes, right? So they've promised to double health spending in the next decade. So they only spend about 4.5% of expenditures on GDP on health. That's really low compared to the US is what, 18%, 19% now? OECD average is about 9%. So they're looking to be around 9% in not too long. And in fact, this is really unavoidable. Now, part of the reason that it's unavoidable is because the aging of the population. But the other part of it, and this is very interesting, is as the country's gotten wealthier and brought in a lot of expats, there's been a big increase in private hospitals. So there's now really good private hospitals in Singapore, and they've created tremendous wage pressure on doctors and allied health professionals. And so for the public sector to keep these employees, they've had to increase wages significantly. And in fact, my government doctors tell me that they could double their salary tomorrow by quitting and going into the private sector. So the public sector is doing all sorts of things to try to keep them. Now what they do for medical students is they have a bond. So if the government pays for anything for your medical degree, you owe them 4 years out. So they do their residency, they're stuck in the public system for 4 years, and then they immediately jump ship and make money. So lots of upward wage pressure. The government is trying to do all sorts of things to reform that, but at the same time, they're doing the opposite and creating essentially more demand by reforming some of these programs. So they've created something called MediShield Life, which essentially increases you can use your MediShield until you die. They're doing away with the annual caps and the lifetime caps, and they're creating more programs for older adults. So they're creating something called the Pioneer Generation Package, which looks a lot like a temporary Medicare program. And so the question that they have to decide, historically, these programs were really focused on inpatient care. And there's been, the world has changed, and a lot of what used to be done on an inpatient, say in the US, is now done outpatient. Well, in Singapore, a lot of those things are still done inpatient just for reimbursement reasons. So for example, I had a knee surgery, which here would have been clearly an outpatient procedure. There I was admitted because they wanted to make sure I could get reimbursement. And this has happened quite a bit, and so the government is now freeing up MediSave or MediShield for use in outpatient services. They're looking at hospice, they're looking at home care services, and so they're in this process of trying to decide what they should cover in these various programs, right? So this is really where my research comes in, and so it's trying to figure out where should government spend their resources, and I'm mostly in this exercise focusing on older adults, but this is certainly a relevant question when you have all of these new and some very expensive technologies. Is it worth it to provide coverage for these things, recognizing that those resources then can't be used for something else? And so the question that we're interested here is looking at, for end-of-life services, when you have lots of new life-extending treatments that are moderately effective but very expensive, should those types of treatments be included in the government's health plan, recognizing that they have significant costs and their ability to improve life or increase quality-adjusted life years is oftentimes quite small, just because they're targeting a population that doesn't have a lot of time left to begin with, right? So here, this is a tricky question for a couple of reasons, but the first thing is if you're looking at preferences for health services or say end-of-life services, one question you might ask yourself is whose preferences matter, right? So on the one hand, you might say, well, we should ask taxpayers, for example, because they're the ones who are, essentially paying their taxes, which are going to cover the cost of these programs. Or maybe it's more relevant to look at, say, older adults, because they're the ones who are going to be most likely affected by these programs, and so their preferences, their willingness to pay would be appropriate. Could be reasonable. Another one would be to say we should look at patients, because they're the ones who ultimately are going to need this treatment, and we want to know what's their willingness to pay. And remember, in Singapore, currently, they're really paying for these services, so it's not like the US or Europe where you have third-party payers. So looking at patient preferences might be appropriate. Now, in fact, in Singapore, I'll give you an example. For cancer treatment, Singapore has some interesting things that are a little bit interesting about it that I don't think you would see here. What I've been told is roughly 1/3 of cancer patients at the National Cancer Center in Singapore either don't know or pretend not to know that they have cancer. And in fact, there's a back door at the cancer center where many of the patients will come in, and they'll come in and they'll get linked up and get chemotherapy. The caregiver, the family caregiver will come in and tell the doctor, we don't want to let our loved one, our parent, our sister know that they have cancer, so you just talk to me and I'll tell you what to do. And doctors in Singapore are totally on board with that. They do it all the time, and the patient is never part of the conversation. And so that begs an additional question of to what extent are caregivers appropriate proxies for patient care, and to what extent are physicians appropriate sort of recommenders for the types of treatment that the patients might receive. So we actually look at all of these groups, and we study the willingness to pay for moderately life-extending treatment, and we also look at how that willingness to pay compares to other things that we think might be important to older adults at the end of life. And we did a focus group, and we published a paper, and we looked at things like pain management, not wanting to be a burden on family members, which we thought might be really important in Singapore, dying at their place of choice, which for many Singaporeans is going to be at home, quality of healthcare services, cost of treatment, of course we think that matters, and then whether the money comes out of your own or a family member's Medisave account or somewhere else. So we thought all of these things would matter. Now, they also matter for healthy individuals who might be voting for certain policies, or say, for example, are having to make a choice about how much to invest in a particular health insurance plan, how much to save for their, for health services they might need in later life. So these are relevant questions, even for people who, are not at facing a life-limiting illness, right? So, just by way of hypotheses, NICE in the UK, many of you know, has a metric, 20 or 30,000 pounds per QoL, in terms of what would be considered good value for money. In the US, you hear things like $50,000 per quality adjusted life year gain. WHO uses 3 times GDP per disability adjusted life year reduced. So our hypothesis really was that willingness to pay for these moderate life extending treatments would be below these accepted thresholds, and in fact, below some of the willingness to pay for these other measures that we think people might also value. So that's really what we look at, and we look at it for all of these different groups. So how do we do it? Well, we use a method called conjoint analysis, which is a stated preference survey technique where we ask people questions over different scenarios and we see what happens, right? And the idea is if we can ask people enough questions and we vary the parameters of these questions often enough, we can then start to predict what they might choose in additional scenarios. And I'll give you an example, I'll make this very concrete in a second. This approach is used quite a bit now in the health industry to look at trade-offs between risk, cost, and efficacy profiles for new drugs and devices. It actually came out of the environmental literature and the marketing literature. It's great for environment or for areas where you just don't have market data. So non-market goods, for example, like saving the rainforest or the whales or something. So a lot of work in conjoint analysis in the environment. I actually used it at one point to look at trade-offs between civil liberties and terrorism risk. And in fact, it turns out people are very happy to give up civil liberties if it makes them safer, right? You can look at it, for example, on preferences for Ebola type screening, for example. So lots of different ways to use this. We used it here to understand preferences for end-of-life treatments. Now, basically, the idea is we identified what we think are the important domains, which we call attributes. We vary them over a range of levels, and then we let people choose. Now, there's some statistical properties that I won't talk too much about. Let me just show you here is the range that we use for the various levels. So for pain, none, mild, moderate, severe, caregiver burden in terms of hours per week, survival in terms of months. Now, in this scenario, we did it very simple. So there was no uncertainty. In other studies, we've incorporated uncertainty in the model, but here we were interested in saying, if you knew this would be with certainty, what would you pay for it? Now, variance might make people be willingness to pay less, but we weren't interested in that in this study. Quality of healthcare experience, cost, and where the money comes from in place of that. And of course, we define all these things very clearly for respondents before we field the survey. We give them a very long lead-in, and we try to sort of educate them along the way, and then we ask them some questions to get them thinking about these different attributes. So I won't go through that process, but let me ask you to take 30 seconds, and this is an actual question from the survey. Now, everybody, don't tell me your answer yet, but think to yourself, if I told you, sorry, you're in an end-of-life experience, or maybe it's a caregiver, you could choose to have this experience, you're in moderate pain, 24 hours a week, expected survival of 10 months, quality of healthcare is poor, it's going to cost $20,000 out of a Medisave, out of a health savings account, but you get to die at home, versus no pain, 10 hours a week burden on family, but you only live 4 months in a very good healthcare experience, meaning care is coordinated, doctors treat you respectfully, the locations are convenient. It only costs $4,000 out of family members out of pocket, but you die in an institutionalized setting. So take 30 seconds and think about, if you were faced with an end-of-life scenario, would you prefer scenario A or scenario B? Everybody got it? Okay, so let me show you one more. Again, take 15, 20 seconds Tell me if you would take scenario A or B. And remember your answer to this one and the first one. Everybody got it? Now, what I will tell you is if I give you 7 or 8 of these questions, I can start to predict with pretty good accuracy what you would choose in a 9th or a 10th or 11th, and how much you would be willing to pay to trade off between the various levels of the other attributes. So let me ask you guys a question by show of hands. How many of you chose A in the first and A in the second? Interesting. Nobody. How about A in the first and B in the second? Raise them high so I can see. Okay, how about B in the first and A in the second? And I see a couple of hands. How about BB? Okay, so maybe the majority. So one thing you can notice just from this group is there's significant heterogeneity in preferences. And in fact, if I were to ask you more questions, you would see even greater heterogeneity. Now let me ask a second question. How many of you focused on one particular attribute and really wanted to choose the best level for that attribute? Which one did you focus on?
The give and take between family care and out-of-pocket for family members.
Okay, so that's 2. So you were trading off 2. Okay.
More of just how much is going to pull out of the family on those 2.
Okay, how about yours?
Pain.
Pain? Okay.
Pain.
Pain? Pain? Anybody choose another one?
Quality of healthcare.
Quality of healthcare experience. What was yours?
Out of pocket, family's out of pocket versus Medisafe,
Okay, so you wanted to minimize your family burden?
and also the length of time survival.
Survival. Did anybody focus on survival, just choosing the best, longest survival? Okay, so let me start to show you what we found. So one of the first things that we look at before we run any types of regressions is we identify people who appear to have what's called deterministic preferences. So they just pick one attribute and always pick the best of that attribute. Now, with deterministic preferences, it could be that they're using what's called a heuristic, meaning they're not really answering the question that we're giving them, but they're answering some other question that we don't understand, like picking their favorite among these levels, right? Now, if they do that, that's sort of problematic because then we're estimating a model that's not consistent with their choices. But it could be that they're actually doing it correctly, but we haven't shown them any other levels that are attractive enough for them to move away from their preferred bundle. So this creates some statistical challenges, but the first thing we do is we look at how many people are dominating on a particular attribute and whether or not we think that's a problem or that might be actually just representing real preferences. So we do that first, and we look at the percent of respondents that are showing these dominant attributes. Then afterwards, we run what's called a random utility or mixed logit regression that allows us to estimate these trade-offs or willingness to pay, assuming that people are making choices that maximize their utility. So they'll choose A over B if scenario A is better than scenario B. And because we have multiple options on individuals and across individuals, we can actually run these models using hierarchical Bayes and get individual level preferences or latent class analysis to get preferences that differ across classes. So as you saw in this group, there were different classes of individuals. Now in this group here, it may be latent. There may be things that represent these classes of individuals that I can't identify. But it's certainly also possible that these, the different preferences that you guys are showing are related to things like gender or race or income that are not latent classes that we could actually model directly. So we try to look at that as well. And then we present the results in a fairly straightforward graphical representation. And we also quantify the willingness to pay to move from your worst to your best attribute in the non-monetary attributes. And so I'll show you those as well. Now in the first sample, I won't go into details, but we focused on a community-dwelling older adult sample, generally healthy, living in Singapore, who we thought would be the ones promoting the various health policies targeting end-of-life treatments. And as samples go, they look more or less like the general population, although not perfect. So I'll call it a national sample, not a nationally representative sample. Now, the first thing you'll notice if you look at the deterministic respondents is a lot of them had, dominated on something. They always chose the best value of something. And in fact, for the general population, 23% of them said, I just want to die in whatever way is cheapest, right? Now, whether or not that represents accurate preferences is hard to say, but it may be accurate. Now, whether or not this is really what they would do when they get older is hard to know. And in fact, well, maybe this isn't a great example, but I'll tell you anyway. When we got a puppy years ago when I was living here, you can get doggy insurance. And, I said to myself, it's a dog, I've got 3 kids, if this thing needs an expensive procedure, forget it, it's just not gonna happen. 3 years later, the dog tears his ACL, needs a $3,000 surgery. My kids are crying, my wife is saying, oh, you gotta do it, and then what do? We got the surgery. So I got it wrong. So it's certainly possible that these individuals are saying, just give me whatever's cheapest, because they're not in that position yet. Right now, if they were to get in that position, they might make very different choices. And we'll look and compare these results to those from the patient sample, and see if they tend to look different. So they were dominating mostly on cost, a little bit on a few of these other things. Now, who dominated on cost? Well, it was lower educated, lower income, more constrained, financially constrained individuals. So that's certainly consistent, right? Now, here is a graphical representation of the results. Now, let me tell you how to interpret these results. Basically, things that are higher represent greater utility. It means people prefer those. Things that are lower are things that people want to avoid. And if you compare one attribute to another, the length of the line tells you how important this attribute is relative to the other attributes as a function of the levels that you show. So if you show different levels, you have a different length of the line. But basically for this sample here, what you can see right away is that cost was the most important, right? So people were saying, I get a really high disutility out of cost. Pain doesn't matter so much, but severe pain gives me a really high disutility. This here, very high standard errors. Amount of cure doesn't seem to matter that much. Survival, we see actually a drop off here. Maybe these guys are saying if I'm going to die in 4 or 6 months, I might as well choose 4. But if I get to extend it beyond 6, higher utility. Quality of care matters, but if it's too high, it seems to drop off. Maybe they're saying that's maybe excessive. Certainly cost matters. And then they have a preference for paying out of their own Medisave account, then cash, and then family members, and there's a higher preference for death at home versus an institution. Seems reasonable, right? Now, if you look at willingness to pay for those other attributes, or moving from your worst to your best, pretty low. In fact, survival was actually the lowest point estimate, fairly high standard errors, but certainly well below these commonly accepted thresholds for cost effectiveness, and in fact lower than the average or the point estimates for these other ones. So certainly willingness to pay for survival doesn't seem like it's the biggest thing on people's minds when you look at the community dwelling older adult sample. Now, if you compare results, say for high and low income individuals, willingness to pay is higher for the higher income individuals, but it's not, again, it's still fairly low overall. So this community dwelling sample is saying, I don't have a high willingness to pay for any of these things relative to these accepted thresholds, but certainly even the higher income group is saying, extending life is not my top priority, right? So let me show you results from the patient sample. So this is tricky, and it's especially tricky in Singapore where a third of the patients don't know or claim not to know they have cancer, because we certainly don't want to be the ones to break the bad news to them. So we had to be very careful in how we engage the patients. So we worked through the doctors and then the nurses, made sure that these were patients that were aware of their condition. We approached them, asked if they'd be willing to take our survey, which isn't easy given, it's a tough thing for these guys to do. And we also asked their family caregiver if they would be willing to take a similar survey. So that's how we got the patient and caregiver surveys. And we did it for 320 patients at the largest cancer center in Singapore and a couple hundred of their family caregivers, right? So our hypothesis would be that for somebody really faced with this life-limiting illness, willingness to pay for everything would be higher than for these community-dwelling older adults, and maybe higher for life-extending treatment relative to these other things. So here's some patient characteristics. These sort of look like general stage 4, and these are all late-stage cancer patients, generally consistent with what they look like in Singapore overall. Now, let me just show you deterministic responses. So we did the patient group. This is a propensity score matched patients where we tried to make the patient sample look more like the community dwelling older adult sample. I won't focus too much on these. Results actually are not that different. But let me show you what you see right away, where 23% of the community dwelling folks were saying, hey, I just want whatever's cheapest. When you look at the patients, that's down to 7%. So clearly cost is far less of a factor for patients than it is for CDOAs, and it's not driven by demographics, because when you adjust for demographics, it's about the same. Patients have a much higher preference for dying at either home or an institution than these guys over here did, whether propensity score matched or not, and a little bit higher over here, but overall, whereas 40%, which is generally high in a conjoint survey for the community dwelling folks, were deterministic, you're over 60% for the patient sample. That's really high, right? Now, whether or not it's using a heuristic, I tend to think not, because it varies quite a bit, and these things certainly seem reasonable. So it's just these guys have very strong preferences, which may not be surprising, because this is these guys are faced with a life-limiting illness. They're making tough choices, and they've been thinking about this, right? So let me show you the results. Now, if you look at the results, well, looking at these graphs, generally speaking, the trends look pretty similar, right? So you see sort of downward sloping here, same sort of thing with pain. High pain is bad. It's not much action here. Now, I will tell you, we thought this would be, caregiver burden would be a big deal. But in Singapore, people use domestic helpers, low-cost domestic helpers for quite a bit. And when somebody gets sick, one of the first things they do is hire a full-time domestic helper from the Philippines or Indonesia. And so it may be this isn't a big deal because they all have domestic helpers who do most of the work. Now, life-extending care is a little bit steeper here than here, or for for moderately life-extending care. This looks the same, a little bit flatter. One of the big things you'll see is this line here, the cost line is much shorter, and in fact, there's a bit of a different ordering in terms of where the money comes from, but a longer line here suggests stronger preferences for place of death. Now, this looks fairly similar, and in fact, you don't see much different here compared to the community dwelling group, but these are all relative, and so let me show you what happens when you look at the willingness to pay estimates. So the willingness to pay estimates, even though, basically because the cost line shrunk some, it means cost is less important relative to the other, so the willingness to pay becomes more important, or greater. And you see much higher willingness to pay, so you're looking at about $20,000 for the patients as opposed to $2,000. And in fact, for all of these things, you see, or most of these things, a much greater willingness to pay to avoid the worst outcome, or to get to a better level. But what you also see is even these numbers here are still below accepted thresholds for cost effectiveness. So if you were using the UK guidelines, for example, you would get if you're using willingness to pay, you wouldn't put some things into your universal plan that you might otherwise, because the willingness to pay for these things is less, right? Now, why it's less we can talk about towards the end, but generally speaking, greater willingness to pay here than here, but still generally low compared to common thresholds for willingness to pay. Now, let me show you the results for the caregivers. Here, if you look at the caregivers relative to patients, it kind of looks like not that different. So, dominance on length of survival is about 9% in both of them. Cost of treatment is actually even less for caregivers than it is for patients. Place of death is you see some dominance here, it's not that different. But the thing is, these 9% and these 9% are different. And in fact, all of these are quite different. So if you look at the total number of deterministic respondents where the caregiver and the patient are showing the same results, it's only 19%. So if you look at these dominant preferences or deterministic responses, what it suggests is that caregivers are not great proxies for their patients because they're focusing on different things. Now, one of the other things here that I think is worth thinking about, and I can show it on the next slide as well, is, generally speaking, our hypothesis would be that caregivers have a greater willingness to pay for just about anything for their patients or for their loved ones, because they don't want to be put in this position of denying anything that could be potentially beneficial. So, this sort of feeling of benevolence or of guilt or, just not wanting to be put in the position of denying anything might make the caregivers be putting more money into these things than they would for themselves or than the patients would for themselves. And in fact, you can see a little bit of that here where the willingness to pay line is actually a little bit shorter. Place of death, strong preference is even stronger than the patients. Much or greater disutility of seeing patients in severe pain, so even higher willingness to pay to avoid this scenario. But you also see a steeper gradient for survival. So a steeper gradient for survival here and a shorter cause line here suggests that the willingness to pay for survival is going to be really high among these caregivers. Right? So let me show you the results. So now we're starting to see numbers that look more consistent with what accepted thresholds for cost effectiveness are. So survival all of a sudden increases from 19,000 to over 60,000. Place of death is more than doubled. Avoiding severe pain is really high. And even the quality of healthcare experience is quite high. Now, these guys, maybe the caregivers don't want to admit that they don't want to be burdened by these loved ones, and certainly the results are consistent with that. But very different preferences and much higher willingness to pay for these caregivers than you would see for their patients. Interesting finding. Now, I will tell you a bit of a side note for this. And actually, this is a project that we're working on a little bit now. What this suggests is it may be that caregivers would actually be better off if some of these treatments didn't exist, right? Because because they exist, caregivers are put in the position of having to fund them, and they might otherwise prefer that these things didn't happen. So if governments are subsidizing or making available some of these technologies, caregivers might actually be made worse off. And in fact, patients too, in some scenarios, might prefer that these things didn't exist. If you give them a scenario, say, of spending money for their kids or requesting it versus using it on life-extending care, they may feel compelled to use it either because their family members or their doctor is pushing them to do it, whereas what they might really like is for these end-of-life treatments not to be available so they could use those money for other things. So we're thinking a little bit about how we might be able to measure that. So let me quickly run through implications, and I want to show you one more thing, and then hopefully in the last 10 minutes we can have a discussion about the implications of these results and maybe whether we think we find something similar here. So certainly pain management is important now. In fact, sadly in Singapore, a lot of patients die in severe pain because Singapore has such an anti-drug culture that the physicians don't prescribe morphine. And in fact, even for people who are dying, they still worry about addiction, which is kind of crazy. So a lot of people do die in pain. In fact, that's generally true all over Asia. Access to opiates is quite bad. So that's something we're trying to work on in our center. Place of death. The reality is that most Singaporeans will die in an institutionalized setting because that's where reimbursement is greatest. And so when patients are sick, they get admitted even though they prefer to die at home. Many don't. So we're also trying to identify funding systems that can help people die at home if they would prefer that. Right? So that's an area where we can really improve. Quality of healthcare experience, I won't talk too much about it. Certainly having great care is nice, but it's also expensive, and if it's too good, that might be not consistent with people's preferences at any level, patients, caregivers, or community dwelling adults. Caregiver burden, as I said, it doesn't seem like it's a big deal because of the access to domestic helpers, which are incredibly inexpensive, and in fact, do some amazing care. In fact, I heard a story about a domestic helper who actually will intubate patients. They can put in the breathing tube, which is amazing to me. But these guys do really amazing work, and they're really the cheapest way to get care. And Singapore relies on, I think there's almost 1 million domestic helpers in Singapore, in a country of 5 million. It's really amazing. So source of payment, this is a Singapore issue. I won't talk too much about it, but I will say as Singapore moves things to be eligible for reimbursement under their MediShield account, people see that money as less valuable than cash, and so they're more likely to use those services for healthcare, and so it's going to increase demand for services, not just end-of-life services. So we'll have implications for healthcare premium increases and cost increases. Cost of treatment. I mean, I think this is really the major issue, and I'll hold sort of the I'd like to get your thoughts on this, but basically, community dwelling adults are not particularly willing to pay for improvements in end-of-life care. Patients' willingness to pay is certainly much higher, but maybe not as high as we might have expected. So, to what extent these sort of really expensive, and there are many new targeted therapies, some based on having a particular genetic makeup, that can cost, $100,000 or more, and so should the government be putting those in their Pioneer Generation package or leaving those aside? Now, if you don't put them in the package, certainly people who have money can still pay for those things, but they wouldn't be subsidized by government, right? So we could talk about that a little bit. Now, why results differ across samples? So I gave you the sort of example of me and my dog, maybe not a great example, but it does point to something that is well evidenced in the literature. And in fact, there's a great paper in Science that talks about what's called the end of history illusion. And basically, what they show in this paper is that although people recognize that they've changed a lot over time, they always think they're through changing, no matter when you ask them. And so, I thought that in a future state where my dog would be sick, I would make the same decision as I was making then. I got it wrong, right? So it's certainly possible that people are systematically underestimating their willingness to pay for these treatments when sick. And if that's true, it has significant implications. Maybe they're buying too little insurance, they're not doing appropriate advanced care planning or advanced directives, or essentially they're telling government to be less restrictive or more restrictive than maybe they should be. But it also suggests that maybe there's a role for government in encouraging people to save more for a rainy day, because otherwise they'll regret that they didn't do it. It's possible. Now, certainly healthy people may be discounting the future, so they see this as 20 years from now, and so they discount the benefits significantly so that their willingness to pay is much lower. Maybe they think their quality of life would be much lower than it actually is, so their willingness to pay. So there's lots of reasons why healthy older adults might have a low willingness to pay. What we're showing here is that they do, and then we can talk about what the implications are. Now, certainly what it suggests for caregivers is that they may not be the best proxies for patients. Physicians certainly should be talking to the patient directly if that's appropriate, trying to encourage the patient to tell you what their preferences are. But in Asia, broadly, Singapore specifically, that tends not to happen. And that certainly could be problematic. Now, I'll skip this. Let me talk a little bit about the physician. So I avoided the physician in this scenario. Now, clearly, physicians, certainly in Asia, where people just tend to listen to their physician and do what they say, have a major sway in dictating what types of care people get. Now, that could be okay, but it also could be problematic. Now, in Singapore, because you don't have third-party coverage and you don't have a Medicare program, there's very little oversight. When a physician tells somebody to do something, it could be the right thing, could be the wrong thing, but there's just not a lot of third-party oversight that might say, hey, this is problematic. And the reality is there's incredible heterogeneity in treatment choices. And that could reflect patient preferences, it could reflect lots of things, but my sense is a lot of it is just physician preferences and physician choices. So let me show you, we gave physicians vignettes, and we varied these vignettes on a couple of different levels, including age, extended survival, median life extending, 5-year survival probability, and cause. And we gave these scenarios to physicians in Singapore, public physicians in the government hospitals, and we just asked them, if this was your patient, would you recommend life-extending treatment or would you not recommend life-extending treatment? And we also varied whether or not the patient had dementia. So let me show you the results, a couple hundred physicians. But here's what we found. So generally speaking, that for older patients, all else equal, physicians were less likely to recommend life-extending treatment. As survival went up, they were more likely. 5-year survival went up more likely. Higher cost, less likely. Now, of course, if the patient had dementia, which is the cognitive impairment, which is the red, less likely overall. Those findings, I think, are not unreasonable. But what worries me here is that, for example, for a 75-year-old patient who's at the median or the average of these other things, whether or not the physician would recommend life-extending treatment is almost a coin toss. Right? And in fact, even for some of these other ones, you're still between, say, 1/3 and 2/3. So very high, heterogeneity in these recommendations for these vignettes. Now, I worry about this, because to me, this says, you go to the cancer center in Singapore, you get whatever doctor was available, and my sense is that which doctor you get could have a significant impact on what treatment you get. Now, I see that as potentially problematic, but I will tell you, when I showed these results to physicians in Singapore, they seem to think it's fine. They say, well, there's lots of things that go into this decision. And I'll say, well, like what? I mean, you only know what I showed you, right? So there's whatever that other thing is, what is it? It's not here. So it's a different mindset over there, but I think that this is concerning, especially if we think the physician recommendation has a significant influence on treatment choices. And so we're looking to try to do a little bit more work here to understand how much of a role these physician preferences have in understanding the treatment choices that patients ultimately make, and whose preferences really do dominate. But I find this to be particularly problematic, especially in lieu of the results I just showed you, where caregivers have different preferences, physicians have different preferences, patients as well. And so how all these things can be reconciled, I think, is something that we still need to do more work on. And ultimately, what we want to do is give patients an end-of-life experience that's consistent with their preferences. And one of the things I'll tell you, and I'll stop here, is we think these contouring tools potentially could be used as a patient decision tool, that we can very quickly give the patient some survey like this in the waiting room, show it to the physician and say something like, this is a patient that has very strong preferences for dying at home or for not wanting to be a burden on families. Can we come up with a treatment plan that's consistent with that? So that's something we're also interested in. So let me stop here and I'll open it up for questions. But I want to thank you guys for hanging in there. Oh, go ahead.
How common are advanced directives in Singapore?
So there's a big push to do advanced care planning in Singapore. Historically, it was not very common, but all of the hospitals now, and in fact there's an agency called AIC, Agency for Integrated Care in Singapore, which is very actively pushing advanced care plans in Singapore. And we actually, my center just funded an RCT to look at the role of advanced care planning in helping patients meet their end-of-life preferences. So there's a big push to do more advanced care planning, which is, I have to confess I'm sort of new in this field, but basically it's a little bit stronger than advanced directives in that it's sort of supposed to be a continuing discussion, because it's certainly possible that people's preferences are changing over time. Any other comments or questions? Go ahead.
So for your sample of patients who were in the hospital, how did you rectify that you were only surveying people who have already engaged with the health system and making this willingness to pay, as opposed to people just staying at home and never accessing health care?
So our sample, I have to be careful in how I present it. So our cancer sample is a sample of patients seeking treatment at the National Cancer Center in Singapore. So if there are patients who are sitting at home who choose, and in fact I know this happens, they know they've got something major wrong with them, but they're going to stay at home as long as they possibly can. So their willingness to pay would be very low. We don't get them in our cancer sample. So what we did in our sample was we went to the doctors and said, can you give us a list of people that you guys are treating, when are they going to be in the office, and do they know that they have cancer, so that we can approach them and ask them to participate in our survey. So, it's clearly a convenience sample. But the reality is, when you're doing this type of work, it's unavoidable. I mean, how do you find those people that you're describing, right? So we have a community sample, but presumably that sample, and we know what the health status is of that sample, but, most likely none of them are sort of late-stage cancer patients. Other questions? Go ahead.
If there's a push to improve advanced care planning in Singapore, is there also a push to address issues of collusion and secrecy?
Collusion and secrecy between the doctor
And the family member?
and the family member? Not really. Not that I've seen. They survey physicians and they ask them, are you comfortable with this? And some physicians will say they're okay with it, others will say no, they're not comfortable with it, they prefer to talk to the patient. But I haven't seen at the, for that to change, basically you need a hospital administrator to come in and say, hey, you must talk to the patient and you must make sure that you get the patient. And I haven't seen that. Now, one thing I will also say, and I have experienced this firsthand in my own treatment, but I hear it over and over, is that the conversation between the doctors and the patients is bad. The visits are incredibly fast at the public hospitals, and there's no time for long discussions and education. It's here's what's wrong with you, here's what I would recommend, what do you want to do? And that's basically it. So we are funding studies to try to improve communication between cancer patients and physicians, but I think physicians get almost no training in health communication. And I will say in the Asian society, as I've seen, doctors are in a position of power, patients go in, they sit there and listen to the doctor, and they don't really question the doctor's opinion very often. They listen, and then oftentimes they do what the doctor tells them. Go ahead.
You mentioned that there's both a private and a public system.
Yeah.
Have you had an opportunity to look in the private system and see whether there are differences as compared to the public?
Private differences in terms of which dimension?
Differences in terms, for instance, what they want for end-of-life care, in terms of what they're willing to spend, in terms of...
The physicians or the patients?
Probably both.
So let me talk, so our community dwelling sample, might be getting treatment in the private system, but the reality is most won't, because it's much more expensive. The wealthy will, and the foreigners tend to go to the private system. Now, the doctors that we surveyed, the reality is most of these doctors either already are in the private system, because a lot of one of the things that the government has done to retain these doctors is they allow them to do 1 or 2 clinics a week in a private hospital. So the same doctor that you see at NCC also runs a private clinic and just charges a lot more money and sees patients in a nicer office at the private hospital. So some of the doctors are the same doctors. Now, for the patients, I can tell you, or I suspect, that it's the wealthier patients that are going to the private hospital, private doctors, and their willingness to pay is much higher. Right? And we know that just because I see what these guys do. And in fact, in the private sector, it's 2 or 3 times more expensive to even get the same exact chemotherapy than you would get in the public hospital. I don't know if that answers your question.
I guess this is strictly anecdotal, but in the kind of Cuban Spanish population, apparently, certainly at one stage, it may not hold now, if you were speaking in Spanish with a physician, he had one view of what dementia and Alzheimer's disease was and what he would tell the patient. If you were speaking to him in English, he had a different view. So I'm kind of wondering if you've got these people who are working in 2 different places. If you ask them in one place, are they going to say something different than if you ask them in the other place?
I'm almost sure they would. If you're seen in the private sector and they know you have money, they're going to be far more likely to give you more aggressive treatment. If you look like me, you're going to get much more expensive treatment than if you're local.
I have a more policy related question
Yeah,
for
sure.
you. I think you mentioned about how those end of life treatment mostly are paid by patients out of pocket.
Mhm.
And then you also mentioned that in Singapore, it's more like a pro-business country
Yeah, for sure.
ideology. And I was just wondering, do you see what will make a case, or what will be the future trend of Singapore government to possibly allocate more funding in terms of the end of life?
Yeah, so great question. So Singapore is more or less a one-party rule, but they worry quite a bit on what the population thinks. I mean, they look around the world and they want to keep the population happy. And the older Singaporeans sort of made a deal with the government that said, we'll let you do what you want as long as you, sort of a rising tide lifts all boats. And they rarely question government. The younger Singaporeans aren't that way, and they're really pushing for reforms in lots of dimensions. And I think for the government to stay in power and to be effective, they're going to have to address some of the inequities in health and in economics, just in general. And so you're starting to see already, Singapore is a very wealthy country, you're starting to see much more government funding of things that historically were left to the individual or the family. So, for example, this Pioneer Generation package is like a temporary Medicare program. It's for the current elderly in Singapore to get health services. We don't know what will be in the package yet, but they're very clearly stating that it's just the current elderly. My sense is, over time, it will stay, and they'll create more like Medicare, more safety net programs. So let me stop there. Thank you guys so much for coming. If there are additional questions, I'll hold them.
Thank you.